శేఖర్ స్టార్ట్ చేసేద్దామా? పెద్ద క్లాస్ ఏమో కదా, జాయిన్ అవుతారు లేదా?
We will start.
Sir, audible, sir?
Yes, audible.
Okay, sir. Thanks. Screen check, sir.
క్రాంతి ఏంటి లేటు?
స్టార్ట్ చేస్తాను సార్.
స్టార్ట్ చేయి.
ఓకే సార్. Good morning, one and all. Today my topic of discussion is IV induction drugs. My moderator is Dr. D. Shekhar Babu sir. What is an IV induction drugs? Drugs, when given intravenously in an appropriate dose, cause rapid loss of consciousness in one arm brain circulation, which is time taken for the drug to travel from the site of injection, usually the arm, to the brain when where they have their effect. Characteristics of ideal anesthetic agent. It should have rapid and smooth onset of action. It should be water soluble, stable in solution, and has long shelf life. Rapid metabolism to pharmacologically inactive metabolites and is easily excreted. Rapid and smooth return of consciousness and cognitive skills. And there should be no pain on injection, no veno irritation or tissue damage from extravasation or spillage. Low potential to release histamine or cause hypersensitivity reactions when given. Lack of cardiovascular and respiratory dysfunction, and absence of postoperative nausea and vomiting or prolonged sedation. This is the classification of induction drugs based on chemical structure. Barbiturates, which thiopentone, thiamylol, methotrexate, phenol group or propofol, phencyclidine group, ketamine, and imidazole group, etomidate and midazolam. Coming to barbiturates, its mechanism of action is it increases GABA-mediated transmembrane conductance of chloride ion, which causes hyperpolarization and inhibition of postsynaptic neurons, which is GABA mimetic and GABA facilitatory. And it suppresses transmission of excitatory neurotransmitters like glutamate via glutamate and nicotinic acetylcholine receptors, and also depresses reticular activating system. And it contains sulfur atom at second carbon atom, which makes it more lipid soluble and more potent. And it is ultra short acting barbiturate, and its one brain circulation time is 15 to 20 seconds. And it is properties of thiopentone. It's highly soluble in water or normal saline. It's highly alkaline solution and it is stable for 2 days. And it is available as powdered form at room temperature. And it is refrigerated form is stable up to 2 weeks. And we in our OT we double dilute it for our induction agent as 1:50 ratio. And contains sodium salt with anhydrous sodium carbonate to prevent precipitation of acid form. pH of 2.5% is 1.05, 10.5. Sorry. Pharmacokinetics of thiopentone. It is highly protein bound, and duration of action is determined by redistribution, and maximum brain uptake occurs within 30 seconds, and subsequent redistribution lowers plasma and brain concentration to 10% of peak levels within 20 to 30 minutes. It's the duration of action. And it undergoes hepatic oxidation to inactive water soluble metabolites. Ultimately, it is eliminated by hepatic metabolism. Renal excretion is important for less protein bound and less lipid soluble agents such as phenobarbital, which comes under this group. Coming to this pharmacodynamics, CNS, dose dependent CNS depression occurs, and we check its effect by loss of eyelash reflex, and it acts on reticular activating system and thalamus, and it can be used as an anticonvulsant agent, and it has anti-analgesic property, and it decreases cerebral metabolic rate of oxygen, thereby cerebral vascular resistance, thereby cerebral blood flow, and decrease intracranial pressure, and it decreases infarct size in cerebral embolia and temporary focal ischemia. Its effect on respiratory system is it depresses hypercapnia and hypoxic drive. Depression of medullary and pontine ventilator centers is seen, and the respiratory reflexes are not depressed until high dose is given. Bronchospasm and laryngospasm likely in light plane added by sympathetic depression. Thiopentone effects on cardiovascular system is at 5 mg per kg dose, 10 to 20 mmHg decrease in BP occurs due to blockade of sympathetic nervous system. Direct myocardial depression occurs at doses used to increase intracranial pressure. Its effect on skeletal muscle is it decreases neuromuscular excitability, suppression of internal cortex, which is mostly seen with Etomidate later, and decreased cortisol level, but it is reversible. Liver, induction of microsomal enzyme and increased metabolism of drugs. Thus, it has interactions with oral contraceptive pills, pentoid, and tricyclic antidepressants. We see increased glucuronide transferase enzyme activity and increased ALA activity and precipitate porphyrias. So it is contraindicated in porphyrias. Coming to clinical uses of thiopentone. It is used commonly induction agent. Dose is 3 to 5 milligram per kg and it produces unconsciousness in 30 seconds. We see smooth induction, rapid emergence. It can be used as an anti-conversion, as I told before. For rapid control of status epilepticus, we give single dose of 3 to 5 milligram per kg followed by infusion rate if it is refracted to conventional treatment. Dose is 3 to 5 milligram per kg per hour maintenance. In treating raised intracranial pressure, as I told, as it decreases cerebral metabolic rate of oxygen, thereby ECP. Dose is 1 to 4 milligram per kg. Side effects of thiopentone. There is pain at injection site, local tissue reaction, and necrosis. Respiratory depression, transient apnea, laryngospasm, these are dose related, and commonly nausea, emesis, and salivation. If you give accidental intraarterial injection of thiopentone, we see intense vasoconstriction, tissue necrosis, and thrombosis. What we should do here is we should keep the cannula there itself, and we should flush it with saline. We should give intraarterial lignocaine or procaine, which is preservative free, and we should give papaverine for local vasodilatation. Dose is 40 to 80 mg, and heparinization, and it is not still yet resolved. We should pain is intense. We should do stellate ganglion or brachial plexus block. Contraindications of thiopentone. It should not be given in status asthmaticus with respiratory obstruction and inadequate airway. Cardiovascular instability and shock, as it causes hypotension. Avoided in patients with sulfur drug allergy, as it contains sulfur. It can be used safely in C-sections, but dose greater than 8 mg per kg cause neonatal depression as it crosses placenta. As I told, it's contraindicated in porphyrias because there is stimulation of mitochondrial enzyme ALA, amino levulinic acid reductase, which is the rate limiting enzyme in porphyrin biosynthesis, which can exacerbate porphyrias like acute intermittent porphyria. In porphyria, we see abdominal pain, hysteria, motor neuropathies, CNS symptoms like seizures, mental status changes, cortical blindness, and coma. Thus, it is contraindicated in porphyrias. Our next induction drug is ketamine. It's also commonly used induction agent. Its structure is phencyclidine derivative, and it is the first anesthetic to be used. It is lipophilic drug which is rapidly distributed into highly vascular organs, and it causes profound analgesia. Coming to its pharmacokinetics, it's highly lipid soluble, which has large volume of distribution. Initial to highly perfused tissues and then to less well perfused tissues. Redistribution results in its termination, and its elimination half-life is 2 to 3 hours. Metabolism extensively in liver, demethylated to form active metabolite norketamine, which is responsible for prolonged effects of analgesia on repeated dose infusion, and is excreted through kidney. Pharmacodynamics of ketamine in central nervous system. It causes dissociative anesthesia, which means it dissociates the thalamocortical system and limbic system, which produce intense analgesia, and sensory impulses from the body do not reach the cortex. Same as thiopentone, unlike other induction agents, it increases cerebral metabolic rate of oxygen, which causes increased cerebral blood flow, increased cerebral blood volume, and thereby rise in ICP. So it is not ideal for neurosurgery cases. And it also can stimulate seizure focus, so not indicated in epileptic patients. It causes emergence reaction while weaning off. It's prevented by prior benzodiazepine administration. Ketamine effects on cardiovascular system. It has indirect increases centrally mediated release of catecholamines from central medulla of kidney. There is increased myocardial contractility, tachycardia, hypertension, increased systemic vascular resistance, and cardiac output. So it is commonly used in hypovolemia and shock patients. Respiratory system, it is useful in bronchial asthma patient as it's a very good bronchodilator and airway reflexes are preserved well. It induces copious salivation, glyco or atropine should be added. Mechanism of action, it inhibits NMDA receptors in cortex and limbic system. Also inhibits serotonin and muscarinic receptors. And it has acts on opioid receptors, antagonists at mu receptor and agonist at kappa receptors. When given IV, it has onset of action within 30 to 60 seconds, and when given IM, within 5 minutes it has onset of action, and orally 25 to 45 minutes. A duration of action is 10 to 15 minutes when given IV. Clinical uses of ketamine. As NMDA receptor is implicated in cerebral ischemic damage, as ketamine blocks this receptor, it has neuroprotective potential. As I told, it causes bronchodilation, so used in bronchial asthma, and it also has anti-inflammatory and spasmolytic action. Septic shock patients, there is reduced need for inotropes, as it causes indirect increase of catecholamine release from adrenal medulla. And in hemorrhagic shock patients, it has sympathomimetic effects. And pain management in cancer pain, neuropathic pain, and ischemic or phantom limb pain. Adverse effects of ketamine. We see emergence reaction while weaning off due to depression of auditory and visual relay nuclei. We see in misperception or misinterpretation of auditory and visual stimuli. Prior midazolam use should be to prevent emergence reaction. And hypertension and tachycardia, as it, while acting on cardiovascular system. Contraindicated in patients with high intracranial pressure, intracranial space occupying lesion, open eye injury, and vascular aneurysm, as it increases intracranial pressure and intraocular pressure. Our third induction agent is propofol. Its chemical name is 2,6-diisopropyl phenol. It available as 1 or 2% aqueous emulsion. It is white in color due to fat droplets in suspension. Aqueous emulsion. It is highly lipid soluble. Constituents are 10% soybean oil, 1.2% egg lecithin, and 2.25% glycerol. So we should not give this drug if patients have egg allergy. It's an excellent medium for bacterial growth. So it should be discarded within 6 hours of reconstitution. EDTA or sodium benzoate are added to impede bacterial growth, and it causes pain on injection as like thiopentone. So we should add lignocaine prior to the reconstitution. So these are two solutions available: Propofol Lipro and Propofol. Propofol Lipro contains both long and medium chain triglycerides in 1:1 ratio, so there is no pain on injection. And Propofol, which is water soluble. Methyl phosphorylated prodrug of propofol. There is no pain on injection, but there is low onset of action with this Propofol. Mechanism of action of propofol. It activates GABA A chlorate channel receptors, thus enhancing inhibitory sinus transmission. Also inhibits excitatory NMDA subtype of glutamate receptors, and its one-arm brain circulation is 15 to 20 seconds. Duration of action is 3 to 20 minutes. Elimination is metabolized by conjugation of glucuronide and sulfate by liver by cytochrome P450 enzymes. It also undergoes extrahepatic metabolism in kidney and lungs. In lungs is 30%. Pharmacodynamics of propofol. In central nervous system, we see dose-dependent CNS depression. Here, endpoint of induction is seen by loss of response to verbal commands in OT. Same as thiopentone, it reduces cerebral metabolic rate of oxygen, thereby cerebral blood flow, cerebral blood volume, and there is decreased intracranial pressure. And it can also be used as anticonvulsant. Cardiovascular system. Propofol causes hypotension due to peripheral vasodilatation. And hypertension is dose dependent. It is marked in elderly and shock patients. So, hypotension, which is avoided by slow injection, and we should avoid inadvertent overdose. Respiratory system. Propofol causes transient apnea. In obtans, airway reflexes swell, and it can be used as an anti-emetic. Propofol. Uses of propofol. Induction dose is 2 to 2.5 mg per kg in adults and 2.5 to 3 mg per kg in children. Maintenance of propofol is 50 to 150 mics per kg per minute. And for conscious sedation, dose is 50 to 75 mics per kg per minute. It can be used as an anticonvulsant and sole anesthetic agent for short procedures like cardioversion, daycare anesthesia, and surgery. TIVA, total intravenous anesthesia. Here, for occurring, the plasma concentration of 2.5 to 8 mics per ml is required, in which is achieved by 1 mg per kg bolus, followed by 10 mg per kg per hour for 10 minutes, followed by 8 mg per kg per hour for next 10 minutes, like that 6 mg per kg, 4 mg per kg, 2 mg per kg thereafter. For occurring plasma concentration of 2.5 to 8 mics per ml. And for sedation of critically ill patients in ICU, dose is 1 to 3 milligram per kg per hour. Propofol has antipruritic and anti-emetic properties. And unlike thiopentone, it can be safely given to porphyria patients. Adverse effects of propofol. It causes hypotension by vasodilatation. And if patients have egg protein allergy, we should avoid this drug. And pain on injection, we should add lignocaine. Propofol causes involuntary epileptic for moments. It is susceptible to growth of microorganisms. Tubings and unused propofol emulsion should be discarded after 6 hours. Propofol infusion syndrome is seen when given in excess of 4 mg per kg per hour for greater than 2 days, that is 48 hours. It is most commonly seen in infants and small children. It is present as metabolic acidosis, hyperkalemia, rhabdomyolysis, renal failure, cardiac failure, hyperlipidemia, and hepatomegaly. Treatment is with hemodialysis and cardiorespiratory support. Next induction drug is Etomidate. It is an imidazole derivative, carboxylate imidazole ester. It is weak base and poorly water soluble. Formulated as hyperosmotic solution, 35% propylene glycol. It's a lipid emulsion available as 2 mg per ml. Pain on injection is common and high rate of thrombophlebitis in postoperative period with Etomidate. Mechanism of action is same. Activation of chloride channels of GABA receptors and enhancing inhibitory postsynaptic membrane. On brain circulation is 15 to 20 seconds. Induction dose of Etomidate is 0.2 to 0.4 milligram per kg per IV. Per kg IV. Duration is 3 to 5 minutes and given IV. Etomidate also causes CNS dose-dependent depression, produce involuntary movements during injection, same as propofol. Recovery is rapid due to redistribution. And its specialty is it's a IV agent with least cardiovascular depression and most cardiac stable, because we see only small reduction in BP and heart rate. Used in shock, elderly, and cardiovascularly compromised patients, as it is most cardiac stable. Etomidate causes transient apnea with induction doses. It can cause hiccups or cough, hence not ideal for insertion of supraglottic airway devices like LMA or IJ. We see increased incidence of nausea and vomiting with Etomidate. It is metabolized by hepatic and plasma esterases. Excretion is by kidney, and elimination half-life is 1 to 5 hours. Adverse effects of Etomidate. We see pain on injection with Etomidate and thrombophlebitis in post-op period. Recovery is frequent with unpleasant accompanied by nausea and vomiting. The characteristic side effect of Etomidate is it causes adrenocortical insufficiency as it inhibits 11 beta hydroxylase enzyme, which is important in adrenal steroid production. A single induction dose blocks normal stress-induced increase in cortisol production for 4 to 8 hours and up to 24 hours in elderly and debilitated patients. And other imidazole group derivative is midazolam. It is water-soluble benzodiazepine. It is lipid soluble. Same as Etomidate. Its mechanism of action is activation of chloride channels of GABA receptors, enhancing inhibitor synaptic transmission. Midazolam is commonly used as pre-medication agent. Onset of action occurs within 30 to 60 seconds. Elimination is by liver by hydroxylation and conjugation. For induction dose, midazolam induction dose is 0.1 to 0.2 milligram per kg IV. And as I said, it's most commonly used for pre-medication. Given in a dose of 0.5 milligram per kg orally, this is possible in 15 to 30 minutes. And can be also used as a potent anti-convulsant agent. And during short procedures, it's given prior. And for emergency reaction also, as I told, with ketamine, prior benzodiazepine use like midazolam can be given. Thank you.
Good morning.
Good morning.
For continuous infusion, which induction agent is preferred for ICU sedation?
Propofol, sir.
Why?
It has less duration of action and it has no much side effects. And hypotension can be managed.
Context sensitivity half-life is less.
Okay. Thank you, sir.
I joined late. You mentioned what is Robin Hood effect?
Wrong. No, sir.
In pentothal, you should tell what is luxury perfusion, what is Robin Hood effect.
Yes, sir.
Nowadays, people are also using keto propofol for short procedures.
Yes, sir.
What are the best uses of ketamine?
As it increases blood pressure, and as it increases blood pressure, it can be used in hypovolemic patients, shock patients.
Okay. Other. It can be used in asthma patients.
Yes, sir. It causes bronchodilation.
It can be used where there is a lack of technical persons, as it can be given intramuscular.
Yes.
It can be most useful is in dressings of burns. Repeated use. Patient will be dressed a day after, once in 2 days. So you can repeat ketamine. Best for burns dressing.
Yes, sir.
How can you reduce the hallucinations of ketamine?
Prior benzodiazepine use midazolam.
If midazolam is not available,
Lorazepam.
and also keeping the patient in a dark room and putting cotton in the ears
Yes. Oh, yes, sir.
to avoid visual and auditory stimuli.
Similar.
What a percentage of pentothal is used in pediatric patients?
Pentothal.
Adults use 2.5%. No?
Yes, sir.
You use the same percentage in pediatrics less than 1 year, or what percentage you use?
Pentothal.
Hmm? You use 1%. You dilute pentothal in pediatric patients.
Okay. Okay, sir.
Good morning. Sir, Adi, ketamine is still considered as an anti-epileptic or because it has got an NMDA receptor antagonist? Raman Prasad, sir.
Madam. It is epileptogenic.
But because it is an NMDA receptor antagonist, they consider it as smaller doses as an anti-epileptic.
I don't have the knowledge, madam.
Okay, sir. We'll just go through again and.
For Etomidate, adrenocortical suppression, you mentioned.
Yes, sir.
In olden days, when there is a scarcity of syringes, some examiners used to ask what drugs are compatible with pentothal to load in same syringe. Most of the drugs get precipitated when you combine pentothal with other drugs, but some drugs can be loaded with pentothal. You can load atropine, pentothal, scoline, same syringe.
Okay, sir. Thank you, sir.
Sir, regarding the previous question, actually ketamine is used in refractory. It's suggested as one of the mainline treatment for refractory status epilepticus. Sir.
Status epilepticus.
ఎందుకంటే కంటిన్యూస్ స్టేజెస్ లోని బేసిక్ గా గాబార్జిక్ యాక్టివిటీ బాగా తగ్గిపోతుంది, అంటే గాబా రిసెప్టర్స్ గ్రాడ్యువల్ గా డౌన్ రెగ్యులేట్ అయిపోతాయి. సో ఇట్ ఈస్ వెన్ ద ఎన్ఎండిఏ రిసెప్టర్స్ యాక్చువల్లీ స్టార్ట్ టు ఇంక్రీజ్. సో విచ్ ఇస్ ద రీజన్ ketamine is actually proposed as in treatment for refractory status epilepticus. So adi theory. Actually, అంటే it will cause raised ICP, but proper ga I don't think there are case reports of seizures induced by ketamine. Only raised ICP physiological consideration మనకు తెలుసు, బట్ seizures చాలా తక్కువ. యాక్చువల్గా ఇట్ ఈస్ నోన్ టు ఇండ్యూస్ seizures అన్నది అంటే రాంగ్ కాన్సెప్ట్ అన్నట్టుగా అంటారు సార్. రిఫ్రాక్టరీలో వాడడానికి రీజన్ అది సార్, ఇందులో మేడం ఎవరు అడిగారు కదా, దానికి రీజన్.
It is also used in refractory bronchial asthma.
Bronchial asthma. Nice class.
Thank you, sir.
Dr. Kanti?
Sir, good morning, sir.
Yeah, the action of ketamine on CVS, what you spoke of, it has a dual action on heart. Okay, two, not clinically, but more in the exam point of view. So
Yeah.
one is a direct action and the other one is an indirect sympathomimetic action. Okay.
Yes,
So
sir.
in the direct action, it is a cardiac depressant. Okay. Especially in people with adrenocortical suppression or insufficiency. And it causes decrease in heart rate, decrease in pulse rate, and decrease in blood pressure. Okay.
Okay.
And the other one, which is more predominant, which we more see clinically, that is indirect effect. It is like it causes increase in heart rate, increase in BP, and increase in cardiac output. Okay. So you should have mentioned it in your slides.
Okay, sir. Thank you.
Yeah, and one more thing, because you mentioned it through NMDA, what are the other anesthetic agents which also work through NMDA?
Ketamine.
And ketamine, nitrous oxide, and xenon. So all of these three have NMDA mechanism of action.
Okay, sir.
Yeah.
And opioids కూడా ఉంటది NMDA antagonist.
Yes, sir.
Okay, any more questions or check?
Yeah, it's a nice topic. It's a refreshing topic. We just need to refresh our knowledge regarding the IV induction agents, and basically targeted at students. who are DMD students who are there in the group. So he presented it nicely, I think, except for a few points. I think if there are no more questions, we can wind up this.
Thank you, sir.
అదే ఈ ఫ్రైడే కేర్ది ఒకసారి మేడం కనుక్కొని ఎవరు చెప్తారు ఒకసారి మెసేజ్ పెట్టు.
ఓకే, నేను చెప్తాను. రైట్.
ఓకే.